Starting far left, around 2100 BC, Sumerian clay tablets reference the poppy as the plant of joy, the earliest recorded opioid use. Follow that history right, and we arrive at the modern extreme of chemical engineering, a synthetic 3D molecular model of fentanyl. Between those 2 points, through the era of Greek philosophers like Theophrastus in the 3rd century BC, medical intervention was purely botanical. Patients consumed the raw, milky juice extracted straight from the poppy bulb. But relying on a raw crop has a significant drawback. A plant's chemical makeup fluctuates based on the soil, the weather, and the exact time of harvest. When the potency of the medicine is unstandardized, a predictable, safe dose is difficult to guarantee. As long as physicians relied on the harvest, they were limited by nature's variability. To gain control over the effect, they had to stop looking at the flower and start looking inside it. That shift occurred in 1803. A Prussian pharmacist named Friedrich Serturner managed to isolate the pure, active alkaloid buried within the poppy. He named this rigid chemical structure morphine. Morphine quickly became the medical gold standard. Because it was a single, concentrated compound, doctors could finally deliver a mathematically precise dose, a level of consistency that raw botanical extracts lacked. Yet, even after successfully isolating morphine and later codeine, chemists were still limited. They remained tethered to the specific molecular structures provided by the plant. So, they attempted to edit the plant's work. In 1874, C.R. Alder Wright chemically modified morphine in a lab. He hoped to remove its addictive properties, creating a semi-synthetic compound known as heroin. But the modification changed how the drug interacted with the body. The alteration made the molecule highly lipophilic, meaning it dissolves easily into fats. Because of this, heroin passes through the blood-brain barrier almost instantly, delivering a rush faster than natural morphine. By attempting to fix the natural molecule, chemists created a more potent compound. This suggested that achieving specific drug behaviors would require bypassing the plant entirely. That transition arrived in 1937 with the synthesis of meperidine. It marked the point where pharmacology moved from harvesting existing drugs to building them from chemical blueprints. These fully synthetic opioids were different. They contained no raw plant matter. Every carbon and hydrogen atom was placed by chemists in a laboratory setting. This approach reached a new level of concentration in 1960 when Dr. Paul Janssen synthesized fentanyl. This chart shows the escalation in potency. The small baseline bar represents morphine, while the engineered fentanyl bar shoots past it, measuring 75 to 125 times more potent than the natural extract. By writing the molecular code from scratch, scientists produced compounds that exceeded the concentration of any plant extract. This provided a tool of high clinical utility, but also created a new scale of pharmacological risk. In modern surgery, the goal of engineering has shifted toward timing. Anesthesiologists require precise control over exactly when a drug activates and when it wears off. This need for predictability led to synthetic derivatives like sufentanil and alfentanil. Because their behavior in the bloodstream is highly consistent, these synthetics became a primary component of modern anesthesia. Chemists also designed molecules with specific metabolic triggers. In 1996, they introduced remifentanil. It is engineered to be dismantled by enzymes naturally circulating in the blood, allowing for ultra-short action and rapid recovery for the patient. Engineering also allowed for a chemical reversal. Scientists developed antagonists, like nalorphine, designed to occupy opioid receptors in the brain and block the drug's effects. The transition from the Sumerian poppy fields to the modern operating room shows a shift from observation to engineering. We now manipulate drug behavior atom by atom, providing sophisticated tools for pain while facing the reality of their potential for harm.